Hi, this is Kendrick with worldmedicalschool.org. We're going to talk about antipsychotics. If you are surprised that we're doing a whole video on drugs, then don't be, because we're going to do a lot more. So antipsychotics are used classically for schizophrenia, but also for schizoaffective disorder, for bipolar, especially in manic episodes. Has been used for OCD and severe depression, and some psychiatrists kind of just like to sprinkle them in for just about any psychiatric diagnosis. The main mechanism with typical antipsychotics is to block the D2 receptor. Atypicals will throw in some 5-HT receptor blockage as well, along with some other things. So the different classifications include the typicals, which are kind of the older ones, and the atypicals. There's not a lot of real meaningful difference between these in terms of what they do, but there's kind of a rough difference in their indications and their side effects. So the typicals, the first ones including haloperidol, chlorpromazine, which is thorazine, and fluphenazine. Those are kind of the big ones that you hear about. The main side effects are the extrapyramidal side effects, which we'll talk more about, the hyperprolactinemia and anticholinergic effects, and neuroleptic malignant syndrome. Now, all antipsychotics share these symptoms to some extent, but the typicals are much more pronounced for the EPS and especially the hyperprolactinemia. Atypicals are more associated with weight gain, type 2 diabetes, sedation, and in some cases agranulocytosis. And again, all of them share the side effects, but the ones that are especially shared are the anticholinergics, orthostatic hypotension, and sedation. But again, sedation more in the atypicals. So among the typicals, haloperidol is the classic antipsychotic, and it's used in both acute and chronic psychosis, but it's one of the few that's used in acute psychosis. It's not very sedating, and it's real inexpensive these days. And so the main side effects with all typicals are really the EPS and the hyperprolactinemia, and the others that we talked about on this last slide with anticholinergic and neuroleptic malignant symptoms. So we've used this slide before when we were talking about schizophrenia, but I didn't really do it much justice then. The major EPS or extrapyramidal symptoms are dystonia, akathisia, and Parkinson's are the acute symptoms, and tardive dyskinesia is kind of the long-term symptoms. I put tardive dyskinesia off to the side here because it is a much longer-term symptom, and it doesn't really have any treatments, whereas these other three, we can treat the symptoms of the drugs with more drugs. So they're put in this order for a reason. Dystonia comes first. Within a day or so you can see some dystonia. Akathisia shows up within a couple days. Parkinson's can be a few days to a month where you start to see these side effects. And we can treat the side effects. The dystonia we can treat with anticholinergics like benztropine, diphenhydramine. And akathisia we can treat with beta blockers, anticholinergics, and benzos. And the antiparkinson's or the Parkinson's symptoms we can treat with antiparkinson's drugs, including levodopa, carbidopa. So this is maybe a good time to take a time out and talk about why we have these side effects. So the basic philosophy behind antipsychotics is that too much dopamine leads to psychosis, whereas too little leads to Parkinson's. So when we overtreat psychosis, we get Parkinson's, and when we overtreat Parkinson's, we can get psychosis. On to the atypicals. Clozapine was the beginning of the atypical age. We've had it around for a while now, and it is actually the most effective of all of the antipsychotics. So it can be used in cases that are refractory to other antipsychotics. And on that note, there has not been a real difference shown in studies among all the rest of the antipsychotics in terms of effectiveness. There has been suggestion, though, that the atypicals do treat the negative symptoms better than the typicals ever did. But other than that, really, there's no big difference in the effectiveness of antipsychotics, with the exception of clozapine. The big problem with the clozapine is agranulocytosis. That's the one thing that you shouldn't forget about antipsychotic side effects, is that agranulocytosis associated with clozapine. It can happen with I think basically any of these others, but it happens enough more with the clozapine that we have to monitor it weekly. So you get weekly CBCs for 6 months, and then you can start doing CBCs, I think, monthly after that. But you have to be really careful with this. So on that note, you don't want to be giving it to somebody with really poor access to health care, poor follow-up options. Olanzapine, or Zyprexa, is again one of the few that we use acutely, and it's really the first line for acute psychosis. It's better than Haldol in terms of symptoms, and but it does have the potential for a lot of weight gain, and it can cause seizures. So that's something that you should remember is the seizure, especially with this one. So don't give your Zyprexa to your olanzapine to epileptics. Risperidone is right after Zyprexa. It's the most often prescribed for acute psychosis. It generally doesn't have as much problems with EPS symptoms until you get over 8 milligrams. Quetiapine, or Seroquel, is used most often in Parkinson's. This is because it actually doesn't affect the D2 receptors. And it's among the only ones that don't have much D2 effect. Although basically all the atypicals have less D2 effect than the typicals do. Causes somnolence and sedation, which is kind of what I'm feeling right now. Then there's aripiprazole, which is also used for depression, but you don't want to use it in adults with dementia. It doesn't cause much weight gain. And ziprasidone really is the one that doesn't cause weight gain. So that one's probably going to be the answer to a question if they're asking about a weight neutral antipsychotic. So in summary, I've got a few questions here. I'm going to try and do this a little bit more than I have been. So what's the class associated with the most weight gain? Atypicals or typicals? That's going to be the atypicals. What's the inexpensive drug used for acute psychosis? That's going to be haloperidol. Which one are we going to use in Parkinson's disease? It's going to be your Seroquel. Which one do we also use for depression? Abilify, aripiprazole. Got to monitor this one weekly. Clozapine, Clozaril. Remember, that's for agranulocytosis. Which one's weight neutral? Ziprasidone, Geodon. So if this is going to be the answer to a question, or if you need to use this in practice, you're going to think about just your overweight patient. You start thinking about Geodon. First line for acute psychosis, olanzapine or Zyprexa. Cardiac arrhythmias, ziprasidone or Geodon. And then the ones that I should have put on here probably are the contraindicated in adults with dementia. Remember your aripiprazole on that one. And potential seizures, remember olanzapine. All right, well, thank you for tuning in. Please leave a comment below to let us know what we can do better. And if you'd like to help out, email me at volunteer@worldmedicalschool.org. Thanks.